Hello, my friends. Jill Osborne from the Interstitial Cystitis Network. I'm here today to talk about the brand new guidelines that were just released for the diagnosis and treatment of IC and bladder pain syndrome. These guidelines will help you find the most effective treatments for your unique case of IC, and there are big changes happening. Be prepared to have your mind blown. So why are guidelines important? Well, number one, they encourage consistency in patient care. We want to make sure patients around the United States are being treated similarly. They provide a best practice approach based on research and expert opinion. And they're excellent educational tools that you can use for family members, friends, and other medical care providers. So who makes these guidelines? The American Urological Association. Every couple of years, they convene a panel of experts who look at the guidelines and decide what to update. Now, these current guidelines were first released in 2011. They were updated in 2014. And this 2022 update represents 8 additional years of research and clinical experience. It was very, very much needed. Now, you've got to remember, though, that the great majority of doctors out there, especially primary care providers, are completely unaware that these guidelines exist. And that is why we have to be the educators here. I'm hoping that I can convince you to bring these guidelines to your doctors to help educate them. So what's new in 2022? Wow. Number one, IC BPS is no longer considered an incurable bladder disease. Let me say that again. IC BPS is no longer considered an incurable bladder disease. It is now considered a pelvic pain syndrome. And the only patients who appear to have a disease are patients who have infection or inflammation. For the great majority of us, they believe that IC has a neuromuscular component, that all those symptoms that you associate with your bladder, that frequency, urgency, pressure, pain, is actually being driven by dysfunctional nerves and or tight muscles. Now, if you followed my live support group meetings, you know for the last 6-7 years, I have been talking about the Chris Payne subtyping system, which I use every day when we work with patients. Dr. Christopher Payne proposed 5 distinct patient groups: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization chronic overlapping pain conditions. Now, for the first time, the American Urological Association agrees. Yes, there are distinct patient groups. And their groups are very similar to Dr. Payne, so they work well together. They just combine a couple of them. So the AUA believes that there are 3 distinct patient groups. Number one, bladder-centric. So patients who have Hunner's lesions, estrogen atrophy, maybe chemocystitis, characterized by a small bladder capacity or pain that improves with a local anesthetic. Maybe you have pain as your bladder fills with urine that is relieved by urination. They believe that that's bladder-centric. Our next group is pelvic floor driven. These are the patients who have tight hypertonic pelvic floor muscles and painful trigger points. And their last group is identical to Chris Payne's group, chronic overlapping pain conditions. So these are the patients like myself who have a history of IC, IBS, vulvodynia, fibromyalgia, migraines, TMJ, anxiety, and depression, etc. There are more. And in this group, we're now targeting the central nervous system. We believe that a central nervous system maladaptation has occurred. Hopefully you've watched some of my previous videos where we talk about this, and I will have more videos that describe this later. So how is IC supposed to be diagnosed? Well, number one, your doctor should do a careful history, and you got to walk in prepared to talk about not only your symptoms, but where is your pain? Is it to the left? Is it to the right? Is it low? Is it high? What makes it better? What makes it worse? Etc., etc. But what I really want you to focus on is your history. When did this begin? Have you had any pelvic traumas? Did you have a hysterectomy? Have you fallen on your tailbone? Were you an athlete? Were you ever hit by a car? Have you ever had previous surgery, like mesh surgery? That history, especially the trauma, will help your doctor really understand all the factors that could explain why you're struggling with your symptoms today. Of course, you must have had symptoms of frequency, urgency, and pain for at least 6 weeks. Patients who have pain as their bladder fills with urine, or patients who are sensitive to certain foods, and we're definitely going to start suspecting IC But doctors should also actively exclude other disorders that can also cause these symptoms, like a UTI, masses, a hernia, pelvic floor tension, pelvic congestion syndrome, etc., etc. Patients who have a history of tobacco exposure should be evaluated for bladder cancer because tobacco is the #1 cause of bladder cancer. Patients who have low frequency or high bladder capacity, in other words, you're not peeing that often, you're sleeping through the night, you can hold a lot of urine, this should prompt a diligent search for other diagnoses because the odds that that's IC are pretty low. And of course, they want you to do a 1-day voiding diary because we need some baseline values here. We need to know how often you're peeing, approximately how much you're peeing, and what your pain levels are, really so that you can evaluate if therapies are working for you, because we don't want you to spend 5 or 10 years doing a therapy that's ineffective, or even 3 months or 6 months. Your voiding diary will help you make better decisions about what treatments you're going to do and if you should stop them, etc. Now, the role of hydrodistension and cystoscopy continues to be minimized by the AUA. They only want you to have this invasive procedure if the diagnosis is in doubt. Letting a doctor look into your bladder, listen, especially if you've had symptoms for a long period of time, I don't like guessing, I like facts, and I think there comes a time and a place where letting somebody look in your bladder is important, and they can do that with a cystoscope. And that will allow them to look and see if there's anything else going on, like could you have bladder cancer or bladder stones or urethral diverticula or a foreign body like a vaginal mesh. If you have ever had a prolapse repaired with mesh, well, that mesh is known to move through tissue and erode through tissue, including into the bladder wall. There is a very good way of looking at the bladder through a cystoscope. It's with something called narrowband imaging. The advantage of narrowband imaging is it will allow the doctor to look for Hunner's lesions accurately without requiring anesthesia. So narrowband imaging is ideal. Now I want you to take a look at this bladder in the lower right-hand corner of your picture here. You see those red spots? We call those petechial hemorrhages or glomurulations. So for 20 years, we thought that was IC, but guess what? That's thrown out now. Petechial hemorrhaging glomurulations are no longer considered specific to IC because they are seen in healthy bladders and other bladder conditions. We actually think this is a residue of stretching the bladder. And so for those of you who were diagnosed 15, 20, 25 years ago on the basis of having glomurulations or petechial hemorrhages, just know that that's thrown out. Big change. So how are we treating? How is that change? Well, number one, AUA acknowledges that no single treatment works for the majority of patients, and that treatment should be tailored to your specific symptoms or subtype. AUA has abandoned the 6-step treatment protocol in favor of something that gives doctors a little bit more flexibility to treat earlier. And I think the biggest challenge with the AUA guidelines is that they are expecting doctors to review the risks and benefits of all potential treatments during what we all know are very short appointments. And I think that that's pretty unrealistic. And that is, again, why you must be educated. I need you, when you walk into your doctor's office, knowledgeable, not only about the basics of IC, about your treatment options. You need to be able to have a good face-to-face discussion about the pros and cons of different therapies, because they're not going to have time to do this for you. And most importantly, if a patient is not responding to bladder treatments, the diagnosis should be considered. In other words, we don't want you to spend a long time doing a treatment that is not working for you. Is there another condition that could be causing your urinary symptoms, such as endometriosis, fibroid tumors, pelvic congestion syndrome, Tarlov cysts, tight pelvic floor muscles, previous injuries like an injury to your tailbone, pudendal neuralgia, where you have pain when you sit down that gets better when you stand up, or if you have that painful arousal sensation, which we call a persistent genital arousal disorder, that's because a nerve is being compressed. So we want to make sure that you don't waste time. If you're not responding to bladder treatments, take a step back, revisit the diagnosis, and let's start asking, what could we have missed? Now, pain care is an integral part of patient care. AUA has said that from day one. Pain should be assessed at every appointment, and a multimodal pain care should be used that includes medications, and yes, that could include opiate medications, manual physical therapy, and stress management. Stress management is important because when you're under stress and anxious, your pain gets intensified. So every good pain management program has an anxiety and stress management course because we need to bring those levels back down, which will absolutely start reducing some of your pain. Last but not least, pain care alone is not a sufficient treatment for IC. If you have Hunner's lesions, yeah, it hurts. Pain care is important, but we also need to be treating the lesions so you won't need the pain care. If you have tight muscles, then we need to treat the muscles so you won't have pain from those tight muscles. Cause and effect. We want to always focus on causation and what can we do to treat the underlying cause. Now, obviously, daily self-help is a must. This is the foundation for care. AUA wants you to check your water intake. Are you drinking enough water? If your urine is a pale, clear yellow, you're good. If your urine is dark yellow or brown, you're dehydrated. That means your urine is super concentrated and irritating, and that's not good. If your urine is clear, then you're not drinking enough water. Number 2, AUA encourages using heat and cold. Heat can help relax muscles. Cold can help calm nerves down. AUA wants you to follow the diet. They want you to consider doing an elimination diet to find those foods that really bother you. You can learn more about that over on the IC Network website. AUA wants you to try supplementation. Now, they don't recommend brand names. They can't do that, so I've just put bladder rest up there because that is one of our most popular supplements. Why do they say that? Because the supplements contain less risk of side effect and adverse events. So the supplements are worth trying. Muscle relaxation. We want to keep those muscles loose and pliant. And of course, we need to work on those anxiety and stress management skills. Mind-body medicine does that. So what are their treatment recommendations? Now understand that AUA lists treatments in 2 ways, recommendations and options. So the recommendations are hard. Yes, we want you to do this. Options are, these are options you can talk to your patient about and consider. So AUA only has 2 treatment recommendations. Number 1, if pelvic floor tenderness or tension is present, they want you referred immediately to a physical therapist. Immediately. They should work to identify trigger points, muscle contractures, painful scars, and connective tissue restrictions. Our goal here is to relax those muscles, get them healthy and normal so that we can improve blood supply to the bladder and other organs. Tight muscles restrict blood supply, so we've got to get those muscles loose, relaxed, and pliant. AUA also wants Hunner's lesions treated promptly. We no more waiting 6 months, a year, 2 years, 3 years, allowing this patient to suffer from intense pain from Hunner's lesions. Now what they're saying is, if you find a Hunner's lesion, you treat it promptly at that time. That's so important because at least in my office, the number 1 cause of long-term pain is untreated Hunner's lesions. So we need to treat these lesions quickly, preferably with fulguration or steroid therapy. So what are our options here? Now options, their oral medication options are fairly simple. An antidepressant, amitriptyline, it might reduce pain and depression. 50 to 64% of patients see results within one month. Unfortunately, the higher doses are more effective, but the higher doses are also notorious for having some pretty significant side effects. Dry mouth, weight gain, changes in your heart rhythm, rapid heart rate, etc., etc. I, for one, was simply unable to tolerate amitriptyline. If you're going to give it a shot, they recommend starting at a low dose, like 10 milligrams, and then slowly increasing. Hydroxyzine is another option that's really much more encouraging, in my opinion, because if you have a history of allergies, using an antihistamine can dramatically improve your symptoms. 92% of patients show improvement. So that's cool. Cimetidine you don't hear very often, but it is also a recommended oral medication. It can help to reduce the acid in your stomach and is extremely well tolerated, and 44 to 57% of patients report improvement. Elmeron, which is the only approved oral medication for IC by the US FDA, has a bladder coating effect, and it may benefit some, but certainly not all patients, and it may take 3 to 6 months to show success. Unfortunately, Elmeron is now associated with retinal disease. It's called pigmentary maculopathy that may be irreversible. So a detailed eye history should be obtained by your urologist before they recommend treatment, and if you have any history of retinal disease, they recommend a comprehensive retinal examination prior to starting Elmeron so that they can very closely monitor for any changes, and that any patient taking Elmeron should have periodic retinal examinations just to make sure their retinas are healthy and not changing in some way. Our last option is Cyclosporin A. Cyclosporin A is an immunosuppressant that may be offered to patients with Hunner's lesions who have not responded to previous lesion therapy known as fulguration or steroid injection. The success rates are high in patients with lesions, with 85% of patients responding to treatment when compared to only 30% in patients without lesions. Unfortunately, the adverse events can be quite serious, including increased serum creatinine, hypertension, alopecia, cutaneous lymphoma, mouth ulcers, and gout. This requires very thoughtful discussion with your doctor and research on your part so that you really understand that this is not an easy medication to take. But it absolutely can be life-changing for some patients, including patients that I've worked with. Now, what are our options for intravesical bladder installations? Well, number one, we've got DMSO. DMSO is the only FDA-approved installation for IC, but it has mixed results, anywhere from 25% to 90% in various research studies. The treatment protocol is 4 treatments instilled at 2-week intervals with a 15-minute dwell time. In other words, you hold it for 15 minutes. And please, a lesson learned here, don't try to drive home with DMSO in your bladder like I did. It can be quite painful. Stay at the health center, hold it for your 15 minutes, then urinate, then drive home. Our second option is heparin. Heparin acts as a protective coating. 10,000 IU of heparin in sterile water 3 times a week with a retention time of an hour showed 56% improvement, and a higher dose of 25,000 IU 2 times per week showed a 72% improvement. Now, lidocaine acts to numb the bladder wall, and when combined with heparin or Elmeron is known as a rescue installation. It's called a rescue for a reason because it can rescue you out of a flare. When you have a rescue instill, normally you walk out of the doctor's office pain-free. And so rescue installations are really the most popular bladder installations around the world at this point in time, but they are short-term. They're not necessarily long-term. Really good to use if you're in a really severe flare. Now, the next thing that we can consider are procedures. Procedures are more aggressive therapies. So, for example, you can have a hydrodistension with cystoscopy, not for diagnosis, but as a therapy. It can be considered in patients who don't respond to oral therapies or bladder instills. They do it as a low pressure, short duration. 30 to 54% of patients find relief. However, it doesn't last very long. I call a hydrodistension a destructive therapy. The reason why you feel better and you get a false sense that you're better is because it destroys the nerves in the bladder wall. It breaks them when you stretch the bladder. But the nerves always grow back, and sometimes more nerves grow back than you originally had. And so that's why it doesn't last very long. Most patients prefer a constructive therapy, something that will help build up the bladder rather than destroy something in the bladder. But anyway, it is kind of an old school option that some patients still do. Of course, we can treat lesions. We should be treating lesions as soon as they're found. Lesions are treated with fulguration or laser therapy that uses heat to kind of cauterize the lesion, or a steroid injection to calm the inflammation in the lesion down. Treatment is very successful with 75 to 86% of patients reporting improvement that can last for a long time, like up to 2 years. Botox can certainly be injected to the bladder wall to silence the nerves, but it also is a short-term therapy. They recommend 100 units rather than 200 units to reduce the risk of urinary retention. Only patients who are able to self-catheterize should be considered for Botox, because if they accidentally silence the nerves that allow you to urinate, you will have to self-catheterize for a period of time. Of course, we have neuromodulation, known as InterStim or urgent PC. This uses a mild electronic impulse to kind of normalize nerve function or re-regulate nerves. This can be considered if other therapies have not provided relief. Generally, a trial is first performed, and if successful, a permanent device is implanted. However, AUA says clinicians and patients should be cautioned that this is indicated for the treatment of frequency and urgency, and is much less effective and potentially ineffective for pain. Okay, so remember, it's going to be the most effective for frequency, urgency. Don't assume it's going to work for pain, because the research just doesn't show that. Studies show modest success. However, adverse events are pretty significant, such as device failure, pain at the lead side, stimulation radiating to the legs, infection, etc., etc. Thus, most patients usually start with urgent PC first, which is known as post-tibial nerve stimulation or percutaneous tibial nerve stimulation. This is done at the ankle with an acupuncture needle. So no surgery is required, and it's much less expensive than a surgical neuromodulation. Now, of course, our last option is major surgery. Major surgery is really rarely used for the treatment of IC, and only in a very small select group of patients who have exhausted everything else and whose symptoms are directly caused by the bladder. So if you have a very small bladder, a small fibrotic bladder, then this is when surgery is often considered. But there is a high risk of failure, especially if you have a large bladder capacity. If your bladder is big, well, then maybe it's not going to work. If you don't have Hunner's lesions, if you don't get relief from an anesthetic installation, if you have pelvic floor muscle tension, if you have hyperesthesia or pain beyond the pelvis, or if you have multiple pain conditions, then it's probably not going to be as effective or effective at all. Those are the patients who have a high risk of failure. And major bladder surgery should only be performed by surgeons with extensive experience with IC and who will be dedicated to your long-term care. If you have surgery, you're going to need long-term consistent follow-up, because this is not easy. This is very difficult surgery with a long recovery time. Treatments that are no longer recommended by the AUA include long-term antibiotic therapy, though this does not preclude the use of prophylactic antibiotics in patients with recurring UTI. BCG, which was once thought would be helpful for IC, turns out the research was poor, and that it's associated with serious life-threatening adverse events. Of course, high pressure, long duration hydrodistension should not be done to reduce the risk of your bladder rupturing, and long-term steroid therapy is no longer considered meaningful. The risk far outweighs the benefits. So who am I? Why am I the person talking to you about this? Well, the IC Network is a health education company specializing in pelvic pain. We also facilitate the largest IC support group in the world. Our website has been twice rated the most accurate and reliable on the web in 2 peer-reviewed medical studies. We facilitate IC Awareness Month. We have a patient magazine, the IC Optimist, that's read by thousands. And we have a mail order center that offers books, chair cushions, heating pads, things like that you might want to consider doing. And my name is Jill Osborne, and I'm the founder. I'm the longest serving IC support group leader in the United States at 29 years in 2022. We also have our patient magazine, the IC Optimist, and it's really important that you stay up to date on all the new information. Things are changing rapidly. And so please consider becoming a member of the IC Network so that you can get this. Our Spring and Summer 2022 magazine covers all these new guidelines, as well as the new European Association of Urology guidelines. And you can download it from your member page immediately, or individual copies are available for purchase. Of course, we have our wonderful new book, IC 101. It's not just a bladder disease, that was released last year, getting rave reviews. Here is a review by Dr. Martha Boone, who said, I would have given anything to have a resource as wonderful as IC101 to direct my patients to. Patients suffering with pelvic pain need simple tools to help them get immediate relief. IC101 is the self-help Bible for pelvic and bladder and prostate pain. It is written with passion, common sense, knowledge, and experience that only an insider can show. And I recommend this book without reservation to patients, family members, and all providers of healthcare. You can get this book from Amazon.com. It's available as an ebook. It's available in our store. It's available as a Kindle. You name it, we have it. We would love for you to read this book. And if you're curious about nutraceuticals, now we get a lot of phone calls every day, especially from patients who are unable to afford traditional therapies, and they want to know what their options are. And as the AUA says in their self-help recommendation, it is nutraceuticals. And so you will find many supplement guides over in our shop on icnsales.com that will kind of walk you through kind of the pros and cons of what some of your options will be. So this is our list of what we believe to be really superior supplements. And last but not least, there is no shame in having IC. You have done nothing wrong. This is not all in your head. You are not alone, and we are absolutely here to help. You can join our live support group meetings. I normally do these weekly through YouTube and Facebook. You can sign up for our e-newsletter on our website. We are here for you. And of course, most importantly, we answer the phone. You can see our phone number right over my shoulder. If you want to just talk to somebody, please feel free to give us a phone call. Because guess what? I actually answer the phone. I don't just have a staff that do it. I work with patients every day, and we'd be happy to kind of help you understand what your treatment options are and kind of work better with your doctor. So anyway, we're here and we would love to help you. Thank you so much for watching our video. We wish you well.